All right. Now we're going to talk the meat of the matter, understanding some of the underlying basics. What are the values of EMG and nerve conduction studies in patients with TOS? I'm going to do these as a question or a point and an answer. Number one, point number one, EMG is focused on motor nerves and muscles. So motor nerve fibers are large and they're myelinated, and they tend to be centrally located within these peripheral nerves. So damage to those occurs usually after there's damage to lots of sensory fibers, which means late stage TOS. I've said it before, I'll say it again. By the time you get atrophy of the muscles in the hand is most common for TOS. By the time you get there, you've had so much nerve damage, it's much less likely that you will have a complete recovery. So we don't want to wait until we see this. We do not want to wait till we see motor nerve damage because that means it's been chronic and severe. All that time you've been getting the sensory nerves at the periphery crunched, and you're getting symptoms, various types of vascular deregulation, color changes in the hand, pain, tingling, burning, numbness. You've been getting that all along before the motor nerve gets damaged. So one of the things that's changed from 25 years ago to now is we don't see as many patients in this later stage. We're making the diagnosis more quickly. A lot of that is thanks to patients spreading the word and the fact that we can access such great sources as Google. Nerve conduction studies are focused on peripheral nerves. And this is true. The problem is that neurogenic TOS, the type of TOS we deal with, and that is the most confusing and challenging, is really a larger, complex bundle of nerves. And so when you study the peripheral nerves, you're just not seeing what's happening with the brachial plexus, and you can't get up there very easily. You can't put pads and electrodes and needles in here very easily. So you have to get this secondary kind of evidence. Nerve conduction studies will only measure the fastest 20% of nerve fibers. Okay, so you have a peripheral nerve, you have motor nerve fibers in there. 80% of them are not evaluated. Or you do a sensory conduction study. Only 20% of those are being assessed. And oftentimes, the small unmyelinated ones are not being assessed at all. So sensory nerve damage in these complex nerves is just often missed. Nobody wants to do a test where you look at 20% of the question and you ignore the other 80% of the question. And unfortunately, that's what a nerve conduction study is limited to. And these are the points that I make. All right, F waves. When you do an F wave, it's this reflected wave that goes back up towards the spinal cord, rattles around a bit, and heads back down the nerves and gives you a small compound muscle action potential at the end. Again, only 2% of the cell bodies in the spinal cord respond. It's a different population each time. Really, this is, it goes through the brachial plexus, which is 5 complex roots and lots of branches. So F waves don't really help. All right, let's take a look at 3 more. I'm going to take these one at a time. The components of the brachial plexus are larger and more complex with a greater mix of nerves than are the peripheral nerves. So when you look at this nerve, the median nerve in the carpal tunnel, it's a pretty small nerve. It may have hundreds of nerve fibers, but not thousands like are up here. So it's easier to find abnormalities. I don't know if anybody knows what this is. This is a section of one of the first transatlantic telegram cables. But you see, if you look at the cut end, how many loose wires are in there. Take a look at this. This is one that came out a little bit later. Or look at this one. This is a modern cable, transoceanic cable. Now, suppose you were in a submarine and you dropped a clamp around this cable and you recorded an electrical signal. You would get one wave. It would be a very complex wave. Imagine trying to separate out what each one of these nerve fibers or wires is sending and receiving. It would be very hard because of all the background and all the mixed signals. So as you go to a more complex nerve bundle, like the brachial plexus, it's a lot harder to figure out what's happening than in a simple peripheral nerve. Now, another thing is that EMG and nerve conduction studies are performed in a standard posture. Okay? What we want is we want to duplicate where you get your symptoms. So we all know that TOS is a disease of reaching. Dr. Newkirk said it, Dr. Jenkins said it. It's a postural disease as much as anything else. We have some narrow tunnels, but we make them much worse, and we stretch or compress the brachial plexus with movement of the neck, shoulder, arms, even our posture upright. And EMG and nerve conduction studies are not done that way. So we're losing some sensitivity. This is important. There is no reference standard for neurogenic TOS. Nobody has a 100% test or even close to it. So when your doctor does an ADSENS test, the accuracy of that test is just pretty low. But when we look at EMG and nerve conduction study, because we don't have a reference standard, no one can tell you how sensitive these studies are. Do they pick up 80% of people with TOS? Do they pick up 8% of people with neurogenic TOS? Nobody knows, because you can't just select a group of people for your study and say, well, to me, they looked like they had neurogenic TOS. Until we have a reference standard, every study like that may be a small step forward, but it's unknown what sensitivity and specificity we have to rule in or rule out this disease. Now, insurance companies and some doctors who don't know a lot about TOS may say something you've heard often. We're going to do an EMG because it'll rule in other causes of entrapment neuropathy. Now, that may be true. You can find a cubital tunnel syndrome where the ulnar nerve is trapped by the elbow, or a carpal tunnel syndrome where the median nerve is squeezed. But you know what? Patients with TOS can have these diseases too. It doesn't rule out TOS. There's a syndrome called double crush or multiple crush, where compression or tension on the brachial plexus causes the nerves downstream to act abnormally. But when you treat the brachial plexus compression, the peripheral nerves get better. So by itself, EMG does not rule out TOS.